Coming up on Why Should I Trust You? We hear it all the time. In public health, everything's a 5-alarm fire. Things are declared absolute. Vaccines, good. Raw milk, bad. Fluoride, good. Even moderate amounts of alcohol, bad. We also hear public health tells you what to do, but rarely explains why. They skip over the risks, and they skip over what they don't know in order to get everyone rowing in the same direction. Critics argue that this approach is alienating many Americans who are information hungry and mistrustful of anything that feels like a decree. Today, best-selling author Emily Oster joins us to talk about health, data. Could a new way of talking about benefits versus risks be the key to rebuilding trust? Let's get started. Welcome!
Welcome.
Welcome.
Hello, everybody. We have a great show today. It's a spicy topic. We're filled with spice. First of all, we got to tell you who we are. Who are we again? I forgot. I'm Brenda Akari.
I am Tom Johnson.
I'm Dr. Maggie Bartlett.
I'm Dr. Mark Abdimalik.
Yeah. Brenda and I are journalists. Maggie's a virologist, and Mark is a physician and also a medical reporter.
Yes. So we're really thrilled to be joined today by Emily Oster, who is a best-selling author of books like Expecting Better and The Family Firm. She's an economist, professor, entrepreneur, mother, and the founder of Parent Data, a website where she says she aims to empower parents by providing the data and tools they need to make confident decisions. So, Emily, welcome to Why Should I Trust You?
Thank you so much for having me.
So we're going to do this funny thing, Emily, where you're going to hang out and we're going to talk about you.
Like middle school.
Yeah.
Like
Yes.
in the bathroom and you're outside of the bathroom stall talking about me.
We're going to whisper about you. No, we want to flesh out a little bit more about your work, your books, your POV on some key issues during the pandemic, and basically how we all get back to some semblance of trust in this country. So first, it's going to be a little bit like This Is Your Life, and just like holler if we get some stuff wrong. We're just going to try this, guys. We're just going to try this. It may be a terrible idea, but we're just going to do it. Tom Johnson.
Yes.
All right, check 1,
It's
2.
time.
Let's go.
Yes. All right. So when it comes to the big books about dispensing advice to exhausted, confused new parents, you got to start with Dr. Benjamin Spock. And he wrote the Common Sense Book of Baby and Child Care. And that was published back in 1946. I was shocked by this. Everyone sort of repeats it. I assume it's true. But, you know, the wrap on that book is that it went on to become one of the best-selling nonfiction books of the 20th century. So Spock basically revolutionized American parenting. And this was right after World War II, right at the beginning of the baby boom. And he's credited with that, often blamed with it, depending on your opinion of the baby boomers. But Spock basically told parents to relax, trust their instincts, and break out of this rigid, authoritarian, rules-based way of child rearing. Like strict schedules were out, embrace your intuition, show affection. And, a lot of people said, that's great, I'm on board. And others said, this is really just indulging American children. So kind of a seminal figure in this. And the next biggie, of course, and there's been many books, but the next biggie is What to Expect When You're Expecting. And this first came out in 1984. Also revolutionary. It's been updated repeatedly over decades. There's been countless spin-offs. But at its core, this book offered new parents something that is, as anyone who's gone through this process knows, is in very short supply, which is reassurance. You're just second guessing everything you're doing. And that's just a little bit of context to lead us to Emily Oster, who we're thrilled to have on today. She has written data-driven books that speak to this new, I guess we could say, stressed out generation of parents who are seeking evidence-based guidance rather than always just these one-size-fits-all edicts or pieces of advice or axioms that, we sort of learn as new parents. This is the way you've got to do it. And that's not always the case when you piece through the data, according to Emily.
Yeah. I mean, Tom, Emily brings a different hat to this. She's an economist. So it's a different way of looking at health data. She has a PhD from Harvard in economics and is a professor of economics at Brown University. And she loves working with data, mostly on health. And it's just data, data, data. But she's also a mom. And that was really the inspiration behind her using this kind of expertise with data to help give better advice to parents. And the result was a book in 2013. It was a mega bestseller, and it was called Expecting Better: Why the Conventional Pregnancy Wisdom is Wrong and What You Really Need to Know. Now, she's gone on to publish other big titles, including Crib Sheet, which is a book about small babies and children, and then The Family Firm, which is about the older kid experience and Unexpected. She sold more than 1 million books worldwide. Now, what is the through line to Emily's books? And it's basically, like we said, parents deserve a better, more nuanced explanation of the findings behind the recommendations. But there's a but. This data exploration has led Emily to some controversial conclusions and backlash from some very influential organizations and leaders in public health who have taken issue with some of her findings. Like, for example, things like pregnant women should not eat sushi. Well, Emily says she looked at the data behind this and wrote that it actually shows high quality sushi's fine. It's okay. But here's the big one.
I ate sushi during my the last trimester. I just want to say that. Don't at me.
Okay. Here's another one. And this one's really controversial. Pregnant women should abstain from alcohol is the decree. But Oster says she's looked at the data and sees a more nuanced picture. She says, of course, heavy drinking is bad. No question there. But she says that the data doesn't really support the notion that pregnant women can't or couldn't drink a little bit. And her conclusion, an occasional drink during the first trimester is okay. And she says 1 drink a day from that point on in the pregnancy is fine. Cue the blowback. The doctors, public health officials, they don't agree. The American College of Obstetricians and Gynecologists and the American Academy of Pediatrics all came out swinging. No. Official guidelines say no amount of alcohol, not even small amounts, are considered safe to drink during pregnancy. And there are experts who've dedicated their careers to the effects of alcohol on babies. And Susan Hemingway, she's the director of Washington State's Fetal Alcohol Syndrome Diagnostic and Prevention Network. She's had conversations with Emily, I think. Pretty sure you've chatted with her, right, Emily?
We were on one show together.
Yeah. So Susan Hemingway, the director of Washington State's Fetal Alcohol Syndrome Diagnostic and Prevention Network, points out that what she sees in her database is different than Emily's conclusions. She says that 1 out of every 14 children diagnosed with fetal alcohol syndrome were exposed to just 1 drink a day. So this idea that you could just have 1 drink a day doesn't really sit well with her. What's wild also is that the science has showed us that 2 fetuses exposed to the same amount of alcohol, and it can be just 1 drink a day, can end up with totally different outcomes. So it's not just about how much alcohol the pregnant woman drinks. The fetus's genetics and maybe the mom's genes play a huge role in how much harm is done. So that's why this, decree is basically the only safe amount of alcohol during pregnancy is none. Susan Hemingway, she goes on to say, as an economist, Dr. Oster concludes a drink a day during pregnancy is safe. As a pediatric epidemiologist, I conclude a drink a day is not safe. So which of us is correct?
And as a mother, I'm totally fucking confused now.
Right.
Did you anticipate that just took off. I think a lot of people said, my instinct as a mother, my instinct as a parent, that a little bit is okay. And then, of course, these organizations come out like, hey, stop the presses here. This is wrong. Did you anticipate the reaction that was going to get?
I mean, so we're now talking about, this book was published a decade ago, 12 years ago, something like that. And so, I think that, did I anticipate it? Probably not to this degree. And actually for a pretty simple reason, which is, about 40% of doctors in surveys say that they tell their patients an occasional drink is fine, obstetricians. And so there's a sense in which what we're telling patients, and this is, I think, part of the source of the confusion, that a lot of what patients hear, and actually, frankly, what I heard during my pregnancy was, don't have too much, an occasional drink is fine. What I wanted to do in the book was really dive into the data and read, what do all of the papers say, papers that are surveying hundreds of thousands of women, papers that are following people over time, and really try to separate the good data from the less good data. And, I think reasonable people, there absolutely are reasonable people who would sort of take a different approach to looking at these data. One of the things that's always been very important to me is that we actually engage on the quality of the data. And so one of the things that I struggle with a bit talking to Dr. Hemingway and some of these podcasts is, the pieces of data, this sort of one piece of data that she's consistently citing is not really what I think most people would consider among the best data. It's kind of a report that is not published out of some data that she's seen from, retrospective reports from people who were not themselves the pregnant people. There's a lot of complexity to the evidence, and a lot of what I built my career on is trying to, read the studies and say, we should be preferential towards a study of 70,000 women in Europe that really surveys people and then follows their kids over time, that's actually more valuable as data than kind of reports from database that's unclear. So was I surprised? One is always surprised at pushback when you feel like, I did all this and I like have all this evidence and here it all is. And it's consistent with what my doctor told me. And I have these other doctors who are like, yeah, that's what I think. Yeah, I was a little surprised, but.
Yeah.
No, Emily, I think I'm so glad that you brought up the amount of data, because that was the questions that were going through my head is, what was the end for this study versus this study? And as we gain more data, we learn new things. And so you used a lot of health analysis and data to influence the public conversation during the pandemic. During the early days, back in May of 2020, if we all remember, you had argued in a Washington Post piece that the data was already telling us that it might be safe to reopen schools. You had commented that kids were faring with COVID did not support keeping the schools closed long term. Critics then and some now say there wasn't enough data to make that call at that point, and that shutting the schools really was about slowing community spread, since we knew kids are transmitting the virus. In the Northeast, it was anywhere between 10 to 25% of school-age kids that were infected in the final school year before the vaccines kicked in. And anyone with kids or anyone who's interacted with a child knows they're a great vector. They're touching everything, putting everything in their mouths. But again, I think when I look back on it, Emily, you had been onto something kind of early that Public Health Today might look back and generally concede that schools stayed shut too long. Instead of, spiking that football, Emily, you wrote a piece in The Atlantic in 2022 that called for an amnesty for public health. As for the schools being closed in those early days, you had looked back and wrote, in spring and summer 2020, we had only glimmers of information. Reasonable people who cared about children and teachers, advocated on both sides of the reopening debate. And I think, that was really eloquently put. In looking at public health's response to the pandemic as a whole, you had written, let's acknowledge that we made complicated choices in the face of deep uncertainty, and then try to work together to build back and move forward.
Okay.
There we go.
So when we come back, we're going to dive right in with Emily Oster. Psst. Hey, do you like our show? Leave us a review wherever you listen to your podcasts, Apple, Spotify, wherever else there is. Thank you. Okay, we're back. And Emily Oster is here with us, and let's jump right in. So, Emily, look, you had written a piece back in November, and really that's kind of that was the article that I was like, I got to call this girl. I got to talk to her. Like, the headline was, there's a better way to talk about fluoride, vaccines, and raw milk. And in it, you wrote, public health agencies typically tell people what to do, what not to do, but they don't regularly explain why, or why people might hear something different from others. They also often fail to prioritize. And the problem is that when people find one piece of guidance is overstated, they may begin to distrust everything. It also requires health authorities to recognize that prioritizing this message means making trade-offs. If health experts share a more balanced message about raw milk, more people might drink raw milk. And yes, that does entail some increased risk. I'm arguing that in exchange, you may get higher measles vaccination. It's not a perfect scenario, but it may mean that fewer people get sick and die, which after all should be the ultimate goal. Now, there were some, I think there was like over 1,000 comments that article generated, folks saying that that Americans are very bad at nuance, that we're dealing with outright liars. When presenting information to them, they'll just dig in further. And someone said, this article seems a bit like victim blaming to me because it suggests that how scientists communicate is the main problem. The main problem is the increasing anti-science and anti-expert bias throughout our culture. So, Emily Oster, tell me how you drew that line, because I find it so fascinating, truly. How did you draw that line between raw milk and getting vaccinated?
For me, that line, I think, is very straightforward in the sense that, as an economist, I think that our kind of core thing is balancing risks and benefits. And so when I think about these issues that we're communicating about, we want to be thinking about, what's the risk of this and what's the benefit. And in this case, I think the risks are sort of I don't know. Those things seem very different to me. Raw milk is riskier than pasteurized milk. We see pretty clearly in the data on foodborne illnesses that the many more dairy-borne illnesses are from raw milk than from pasteurized milk. I mean, pasteurization is a proven way to kill bacteria and other things. But the number of illnesses that are caused as a result of consumption of raw milk is actually quite small. And, reasonable people thinking about, correctly sourcing the raw, like reasonable people drink raw milk. I don't drink raw milk. I wouldn't drink raw milk. I don't think it's a crazy choice for anyone to make. And when we communicate, I think it's really important to explain to people, this is the size of the risk. This is the number of illnesses that we expect, and that number is small. Another way to say it is that number is like within the range of the kind of risks people are taking every day. And I think another important piece is it's kind of it's a personal risk. Like it's an individual risk. You drink the raw milk, maybe you get sick from the raw milk, and then you feel bad. When we think about something like measles, it is both very clear, much clearer, that there are benefits to the measles vaccine, and there are much larger impacts on the sort of broader world. So if you had to, I guess another way to make this whole point is I think that when we communicate about public health, we are often giving people a list of things and saying, here are 75 things, do them all. And we don't prioritize at all. It's just like, don't drink raw milk, use fluoride, get your kids vaccinated, eat 175 grams of protein every day, don't smoke, stand outside drinking lemon water in your bare feet under the sunlight in the morning. Like we just give them this whole list of things. And we don't say like, by the way, not smoking is like quite a lot more important than avoiding raw milk. And measles vaccines are a lot more like, we don't do any prioritization. And that makes it very difficult for people to make decisions in a world in which they are constrained or they have other preferences. And so I guess in all of these spaces, I'm really almost always advocating for just try to give people more information. And I will say, I do not like this argument that like people are too stupid to understand nuance and like we should just be lying to them. I think that is whether people would have said it like that. I think some of the messaging during the pandemic had this feel of like, we're going to tell you what to do because we're the experts. Even if you think that in some way that's true, it backfired in terms of people's behavior. Right. And I think if all we care about is actually outcomes, which for me is like sort of the most important thing, I still think this isn't the right approach, even if you just care about outcomes.
I would say on the raw milks thing, like, let's go back because I want to like play that out. Because I think what I'm hearing you say is individuals, if they choose to drink it, it carries lower risk. I guess my question would be that from public health's perspective, they're often trying to issue guidance for populations, right? And they're trying to issue guidance for not just an individual to make a decision for their own personal life, but they're trying to issue the guidance for. And I guess, is there validity to if large swaths of the population start to drink something that's unpasteurized, the risk does go up in terms of if you have one or two people, but then and again, I'm not a numbers girl, but like if a bunch of people start doing it, does that up the risk? And ultimately, isn't it the job of public health to sort of mitigate, even if it's a small amount of risk and over a large population that could be dangerous?
I would say yes. I mean, that is the job. That is the job of public health. I think we have to ask the question of whether the way that we are communicating that is helping helping the cause of this. I think in the particular case of raw milk, like, yes, sort of in some historical context, raw milk used to be an important source of tuberculosis outbreaks. That's really not true anymore, given the sort of sources of our given how people get tuberculosis and other things about raw milk. So I think the kind of broad population level risks of this are quite a bit lower than you might think. But I think it is right that if you just went out and started saying like raw milk is as good as pasteurized milk, or there's really no risks to raw milk, like I would not advocate that. I think what I'm trying to hit here is a balance of saying, what we could say is raw milk is less risky than is riskier than pasteurized milk. And if you want to have the milk that is least likely to give you foodborne illnesses, you should drink pasteurized milk. And we recommend drinking pasteurized milk. If you're going to drink raw milk, please make sure that you're, sourcing it from a high quality source, whatever you want to say. That seems like a perfectly reasonable message to me. And I wouldn't say we should say, raw milk's perfect for everybody, because it's not true. What I think comes out in many of these messages is not only, raw milk is riskier than pasteurized milk, but if you are a person who drinks raw milk, you are like a tin hat conspiracy theorist nut who doesn't believe in science. And we believe in science. And we've somehow left no space here for people who say hey, I believe in science. I want to vaccinate my kids. I want to do these things. But the farm down the road has this really really amazing milk and it tastes delicious. And I know the farmer and like, he's my best friend. And we get like, they deliver the milk to our house. And like, we're telling those people like, you're a nut job for doing this. And that feels like a message which may lead people into a space where they are not going to be doing the things that you really care about them doing.
Yeah. We're, as Brenda alluded to, we're so hungry for sort of different approaches. And I think some in public health are open to sort of shaking things up because the old system didn't work. I just want to talk about the strategy of sort of giving a little bit and easing a little bit on raw milk. And it really clicks together when you say like raw milk is an individual choice. It's not going to affect a population. It's not going to hurt vulnerable people down the road from you. If you just look at this as a strategic maneuver, talk about how you could see this bringing us back to a place where more and more parents increasingly are getting their children vaccinated, as versus what we're seeing now, which is more and more parents are easing up on vaccination. Like, how does changing our messaging on something like raw milk and putting our shoulder into vaccination, like, how do you see that leading to a better place or a better trajectory than we're heading in now?
Well, I think there's a couple of things. So one is that I think it would open up space for spending more time thinking about the sort of messaging that we care the most about, right? I mean, people's time is finite. The time of, the resources of any kind of public health agency are going to be finite. And I think thinking about, how are we going to message about the things that we think are particularly important, that's going to compete for time against the things we think are less important. I also think when we do this, and this was sort of the point I was making, the Times piece, that when we are communicating all of these things at the same time, it actually gives the kind of, I don't know if we want to call it the other side, but the sort of skeptics more space in to say, look, these people are telling you that raw milk is also bad. They're telling you this and that. And you should listen to me on this. And then you should listen to me on this other thing. It also is true that that a lot of how we're going to ultimately, if we can sort of pull back vaccines into being more common, that's going to be the work of pediatricians. And if we can help pediatricians say, here are the really let's hone your message. Let's focus your message on like the things that are really important. And here is what they are. I think, again, it's a sort of time, like how do we have enough time to do these things? I don't know. Yeah. I mean, vaccines are having a tough moment, obviously, because vaccines are having a tough moment. Let's put it that way.
I think what vaccines is one of the most important things that public health really advocates for. But Emily, I want to step back for a second. Just, can you explain to me what the difference is between an economist approach to all of this and a health approach to all of this, or an epidemiologist approach to all of this? Like, what are you bringing into this equation that's different, and why should somebody trust an economist take on this versus, say, the traditional public health experts or epidemiologists?
Yeah. So I would say, first of all, I think that the sort of reading of the data is very similar. So at the end of the day, there's a bunch of data behind these things, and we're all kind of seeing the same data. My expertise is in data analysis. There are a lot of people in epidemiology who have a version of that same expertise. And so in some ways, like the kind of what does the data say piece is really I think in some ways the skill set is very similar. Have maybe sometimes a different view on causal inference, but like fundamentally, this is a very similar set of information. I think the two places where the approach that I take here differs some from public health. I think one is in more of the weighing of cost and benefits. So we mentioned a little bit at the top some of the stuff during the pandemic. And I spent a lot of time in the pandemic talking about schools. And I think I took a view, particularly towards like not in the spring of 2020, but in the fall of 2020, I took a view counter to many people in the public health space that we should reopen schools. And I think part of that was, I was looking at the data, and I think part of it was the thinking about the trade-offs and the losses to not opening schools. Whereas I think in many cases, the public health approach, and I think many people in the public health establishment have been pretty clear on this, that like the public health approach to this was saying, basically, our goal is to limit the amount of COVID that people have. Like our only goal is to have less COVID. And if schools have any COVID, like that's a reason to keep them closed. And I think the kind of cost benefit sort of broader view maybe that comes from being in a different field was to say, hey, there's this risk of COVID, which we for sure want to think about, but also there's a risk of, learning loss, and there's a risk of, kids, other bad things happening to kids, and that we're kind of trading off the cost and benefits. So I think there's a thing people hate about economists, which is that we trade costs and benefits. I also think it's a little bit of our superpower, and I think that's a place where I differ. I think the other thing here is really just a kind of difference in almost a psychology view about like how people process stuff. And I think sometimes the view in public health ends up sounding to me like we think if we just yell louder, like people will hear it more. And I don't think that's working. And I think that, this sort of behavioral economics kind of nudges stuff would sort of say like just yelling at people that they need to do these things is not always as effective as we might think it. But I'm not sure that's a field view as opposed to just a kind of, different people have different views about how humans process information.
Yeah. I mean, we keep hearing that public health is just shouting orders without explaining why. And the list of 75 things. And I don't know. I just feel like that isn't really, accurate. Is it really is that a misread of both the science and the moment? I mean, public health is always wrestling with uncertainty, and you do want the clarity, especially when lives are at stake. And that's the job of public health. And so to criticize that approach, and maybe that's just what people are hearing, and that's one thing.
That's a different thing. Like what people hear is different from what public health says. I mean, that's.
But do you let me ask you, Mark? Do you disagree with what I said about how this worked during the pandemic on the school stuff? Like, do you think that public health was seeing that in a more nuanced way and just somehow coming out on the view that school was not important?
I don't think anybody thought school was not important, and I think that. I mean, I wonder even the way you approached it, you said you were looking at the data, and everybody came to the table with what they wanted. Like Fauci and, Collins, they came to the table with their job was to just limit the amount of COVID. Their job really wasn't some of the downstream effects of schools and the economy.
If that's the case, so maybe I think maybe what I would say is I think then the difference is you could say, the job of Fauci was to think about that. And the failure was not there in the public health establishment. The failure was in the government to combine Fauci's. We should have said Fauci says, this thing about schools, but, the Department of Education says, and we're going to bring somebody in to do the trade-offs. I guess what I would say is I thought I was trying to do the trade-offs. I was trying to do that.
And you were supplying key context,
and I was collecting all.
But did you just guess right too? Right, so a lot of time is hindsight.
I spent a tremendous amount of time during the pandemic. I mean, I ran the largest COVID data source.
Yeah, which was cited heavily.
I collected all of this. So I wasn't just. I think it's not right to say I was just guessing. I spent a lot of time both collecting data, collating data, thinking about data. I mean, this is my job. I don't think it's fair to say I was just guessing.
Well, let me ask you this, Emily, because the thing I wrestle with is that how do you square the fact that there were kids who died, right, during COVID? Like at one point, I think even 300 kids were dying a year. Is there a yes and approach here where in a novel coronavirus, where certainly early data is maybe showing that kids were not as vulnerable as other populations, but yet they were still vulnerable and we weren't sure how this thing was going to mutate. And of course, the first thing we want to protect are our children. You want to overshoot on your protection.
Absolutely.
Policy,
I don't think
right?
I just want to be clear. I don't think anyone on this call or any of these discussions is suggesting that we should have taken the approach Sweden did and leave schools open the whole time. That may have turned out to be the right approach, but I don't think anyone is suggesting that that was not a reasonable thing to do to close schools in March of 2020. I think where we came, where the school debate has been more active is in the question of what should have happened in the fall. In the fall in the US, some schools started to open in July. At that point, we had data from the UK, which had been open for several months. We had some data from Israel. We had some data from other places in Europe. We had some data from daycares. We had some data from summer camps. By the time there was reopening and there's a possibility of reopening in the Northeast, we already had a bit of data from, some places that opened earlier. So we knew some more in the fall. And then there were like very different choices. There are school districts in the US that were open from, day one all the way through that school year. And then there are school districts that never opened. And so there's a lot of variation in the choices that people made. And I think where the disagreements are is the question of, should we have had that level of variation? Was it reasonable for school districts to remain closed post-vaccines through the end of the 2021, 21 school year? I think that's where the debate is, not in this question of kind of what should we have done in March of 2020, where I think, certainly there are people who will say we shouldn't have done that. We shouldn't have done that at all. But I think it's, I think the position that was a reasonable thing to do is very mainstream, and certainly one that I would take. I think where I wish we had made different choices is in the fall when, the schools in where I live opened and the schools, down the street did not open. And ultimately, the outcomes in terms of COVID illness for those places were extremely similar.
Yeah.
And did not seem to be affected to the most, by the school reopening. And so I think this argument of, some kids got sick from COVID, some kids died, that is incredibly tragic. That's not really related to school reopening.
I mean, I think to me, if we just take a step back, it's not even like this nuanced discussion about school closures is great. I think it's also that just we paint everything with just one brush, that, the public health is just too simple. It's a shallow recommendation, and the nuance isn't there. It's almost like we need to explain that the message may be simple, but the science behind that isn't necessarily simple. And it's just not a time where we need to, we don't have that time. Like you said, even in the amnesty paper, we don't even have that time to discuss all of like that nuance.
Or do we?
I think we should try. I think my view is that we should be making more effort to think about how much of the nuance we should communicate. That's all. Yeah. That like there is more space. My view is that there is more space than we are giving it for communicating the nuance about why we think this to people. Like we are too frequently telling people, I think this because I'm an expert. And I agree, you did look at the science in the background. But what I'm saying is I think people would be more receptive if you said, let me explain to you an example of the kind of piece of evidence I'm looking at and why it might be better than this other piece of evidence. And I think.
But that is out there. I mean, the data is out there that people can look up. And that's sometimes where we get into.
But we are making it easy for them, Mark. Like we're not making it like, let me give you an example. So I do work a lot in obstetrics. This is not a fraud example, but I work a lot in this sort of pregnancy space. And one of the kind of key interventions that is currently a good idea is baby aspirin for prevention of preeclampsia. Yeah. So the risk of preeclampsia is reduced by about 20% if you have baby aspirin during pregnancy, and a huge share of people are at risk for preeclampsia because obesity is a risk factor for preeclampsia. Yep. Okay, so basically almost a huge share of pregnant women should be on a baby aspirin dose. It basically has no downsides. Yeah. When we communicate that, I talk to people who are like doing this kind of communication in like Medicaid populations. The way this is communicated to people is take a baby aspirin. It's a good idea. I'm an expert. Here's the baby aspirin, but not like why. Or maybe they say here it's like for preeclampsia, but they don't know that they don't have preeclampsia. It wasn't diagnosed. We haven't. I think even in that space, we would be better off. And then people don't take it. There's no like the uptake of the medication is lower than it would be. I think if we showed them a picture, we said, look, we did a study with people. Some of them got the drug and some of them didn't. And the risk for this preeclampsia was lower. And here's a picture of how those numbers are different. And this is why you should take preeclampsia. That's a 3-minute lecture. And it isn't coming through. Now, you could say like, well, that's like, we are doing that. But I'm saying that what I'm seeing when I talk to people in the world is that isn't happening to the extent that it should.
So that's public health. Take the baby aspirin. Your doctor's job is to do that 3-minute explanation. Sure. So we're conflating public health and criticizing public health when their job is to put out a simple message, right? They've done through all this. This is the simple message.
But maybe the job of public, I understand. So I hear you absolutely. But I think also that, we could work in the public health space to say like, we're going to provide resources for people to make it more possible to convey this in reasonable. And again, I want to be crystal clear.
Maybe some marketing materials. Like here's some marketing materials.
I'm not here to say it's not that I think the public health is terrible. I think, my view is that we could be doing better on some of this communication.
Absolutely.
I do think there were mistakes made during the pandemic. I mean, that's we could disagree with whether they were mistakes, but I think that, the school closures were a mistake. But I don't think there's I don't have a problem with public health as a sort of general, like writ large. I just think that we could spend more time on the communication piece of it, and whether that is helping pediatricians communicate, whether that is communicating directly. I think there's a lot of scope there for not just coming to the conclusions, but explaining the conclusions. And then there are spaces, absolutely, where I think I would say I read the data and I don't think that the public health read of the data is correct. And a lot of that is really just about a difference in kind of expertise and basically my view about how much residual confounding we should really be accounting for. And that's a much more technical position having to do with my where I sit in my academic work.
I think what's so interesting to me and what I heard from both of you is that there's a lack of the implementation piece. I felt like public health was messaging. I don't think it was making it to the public effectively. I think the government ultimately takes the recommendations of public health and then has to execute it, whether that's making sure that physicians have the tools and training to have these types of conversations. That ends up getting into the whole mess of healthcare in the US, which we talked about a little bit in a different episode. But I wonder if you might talk about this space in the need for implementation. So we should have experts discussing all the pros and cons, but there needs to be that continuation to how does this get to everyday people? Because everyday people don't have time to source through the data, nor does everybody want to. You and I will sit behind a pile of data and just be loving it. But when I was a waitress, not what I had time for.
Yeah, I mean, I guess my view on this, which I'm curious what Mark's view is that there is potentially a space for this kind of more official public health bodies to accompany recommendations with some notion of marketing materials is a little bit of a pejorative way to put it, but explanations and marketing materials, and this sort of thinking carefully about what is the most effective way to communicate why we have made this conclusion to a potentially, open, but then potentially skeptical audience. And that piece of it, these the American Academy of Pediatrics spends an awful lot of time thinking about what the recommendation should be on various things, but I think relatively little time thinking about how we can effectively explain them and why we came to those conclusions to a public audience. And I would like to see a little bit more of that second piece. I think it would be helpful for practitioners to not have to roll their own on all of that kind of communication piece, because that is a skill. I mean, that's sort of communicating nuanced concepts about data to people is actually itself a skill that one could develop. I mean, it's my only really core skill.
I mean, in our conversations with the Make America Healthy Again movement, and there's several people who really follow the tenets of that movement who we've invited on our show, and they will often say that they're very hungry for data. They're very hungry for information. I think where, COVID was obviously was a 5-alarm fire. When you have a situation where something feels like such an emergency, and we can talk about whether it even needed to be characterized like that the whole time, but when something feels like an emergency, it almost seems like public health is all that public comment period and stuff is great and all, but now we're in it and we got to row in the same direction, right?
Yeah.
Can there still be room for nuance and, a true explanation of, the thinking behind those public health decrees during a public health emergency?
We keep using this analogy of 5-alarm fire. Let's stop using that analogy, right? So a fire alarm, in the building, a fire alarm goes off, right? It doesn't tell you where the fire is. It doesn't tell you how big the fire it is. It doesn't tell you if it's a bathroom burning in the candle or there's an elevator blowing up on the 13th floor. It just says, you're in danger, get out now. We'll figure out later if it was a false alarm or if it was a big deal. Public health is the same way. And sometimes, I mean, it trades this nuance for urgency. And I feel like we should move away from the 5-alarm fire analogy. The issue is, what do we do when science is seeing something that's going to percolate up, and we expect science to have answers for you, like Maggie's doing research on bird flu, for example. I don't know if that's true, but
It's true.
It's true. So she's seeing something that needs to get out there, but for right now, it's not an emergency. But if we take these 5 steps, maybe it never will be. But anyway, Emily,
let me I have like one reflection going back to where Brenda started, which was the question of like, in this moment of emergency, like what do we do? And
Yeah.
I guess I think that part of the issue is that in those moments of emergency, there is, whether it's a 5-alarm, whatever is a thing, like there was, at least during the pandemic, relatively little willingness to talk about, what do we know now and what will we know in the future? The analogy that I always really like is like when there is an actual fire, not like in your house, but like a wildfire. Right? Like, how do they communicate about wildfire? It's like every day the fire marshal gets out in front of like the press and says, here's where the fire is now. Here's the map. Here's where we think it's going to go tomorrow. Here's like the uncertainty. And I'm going to come back tomorrow and I'm going to tell you like where and when and what we're going to do next. And during the pandemic, I think we did not do enough of that particular kind of communication. And instead, we had this sort of back and forth, like masks are bad, masks are good, this kind of mask, this good, like, and then people just like stopped listening, right? It's like if you sort of came up and you were like, I'm 100% sure this is where the fire is going to go. And the next day you came and you were like, just kidding, and went to this totally different place, but now I'm 100% sure that's going to go. You only get like one of those before people are like, meh. And I think we could, in those moments, both say this is incredibly important, like bird flu is something we are very worried about, and also say, here are the sources of uncertainty. We don't know the extent to which there is human-to-human transmission. Here is what we know. There has been more transmission to cows, and we know that cows are closer to humans than, birds are to humans. And so that makes us more concerned. And I'm going to come back next week and explain to you what's happening with this. Like that kind of messaging, I think, helps bring people along and helps them trust you. Because ultimately, all we're talking about here is like trust, and whether we trust people or don't trust people. And if public health loses people's trust, which it did a lot during the pandemic, it is very difficult to get it back. That's the fundamental problem. Like you can't it's not free. Like you lose it, and then it's so hard to build, and then in like 1 second it's gone, and then it's very hard to get it back.
I want to go back to one thing you talk about, which is pregnant women, right? Like that is something that you have focused a lot on. And I think that, when one is pregnant, it is like a really interesting kind of snapshot of, in some ways, what it's like to constantly be told rules about what you can and can't do, and feeling as though if you don't follow that rule, you could be putting your baby in jeopardy. I'm wondering, in some ways, like, what have you learned through like the obstetrics and just the process of pregnancy that has, whether it's through data or through your conversations with pregnant women, that makes you think like this is a population where we are doing a disservice by laying out, and if this is what you're saying, Emily, I don't want to put words in your mouth, but like that are we doing this population a disservice by being so kind of blunt about rules that, of course, for mass populations, it's important to keep women healthy so their babies stay healthy?
I think one of the, probably the most common reaction I get when people tell me that they read my book and they like it is like, your book was the first one that made me feel like an adult. And I think that there's an experience of pregnancy for many people where it is infantilizing. It's like a series of rules. It's a series of kind of again, I think that doesn't always have to be true, but and many providers don't. This is not to say like doctors are crappy or whatever. Like I have many doctors that I love and who I don't think make their patients feel this way. But the reality is I hear from a lot of people that this is how they feel during pregnancy, and that being treated like an adult who is able to make their own decisions is a very important part of feeling like you're in control. And even if those decisions, and I guess maybe this is the point, like even if those decisions are exactly the decisions that your doctor would tell you to make, we talked about alcohol a little bit at the top. I talked to a lot of people who are like, I read your book and I decided not to drink. That wasn't for me. And, it wasn't, but that decision feels better to them feels more like a decision that they made based on evidence and thinking about their preferences or whatever than sort of listening to a list of rules. And, maybe that person also would like occasionally have a hot dog, even though that's like on the no list. And so I think this feeling of infantilization is something that adults do not like.
Emily, I want to take you to the here and now with the new sort of public health team. So we've talked about the old public health team in the pandemic, and I just jotted down, they perhaps were times were too declarative. They didn't offer the reasoning behind their decisions. They didn't discuss openly the nuance that the data and the research really, we live in a nuanced world. They weren't discussing that. Just a few days ago, the new team, which was, Robert F. Kennedy, Jay Bhattacharya, Marty McCary, they post a video saying, and I'll just choose the part that is in your wheelhouse, which is pregnant women. We're no longer recommending that pregnant women get the COVID vaccine. The video is like really short, didn't explain the nuance, didn't talk about what changed in the research, was pretty declarative. And we're not even getting into sort of then the CDC posts, hey, this really is ultimately a decision between you and your doctor. What did you make? Because this is the team that came in who's all going to be about transparency, right?
Right. Look, I mean, I'm very torn here because I will say, I wish that the sort of old previous public health administration was more nuanced in their communication. I do think that there is work to be done on this. But at the same time, I also what these guys are saying is not right, or is certainly worse in terms of its support in the evidence than what has been done before. And so there's a difference of degree. I'm particular around the routine vaccinations. I feel like, the fact that we are out there telling the public health administration is out there telling people that vaccines cause autism, or that that's still a very open question, I feel is substantially worse than telling people vaccines are safe and then not fully explaining it. What I think is that if we want people to get more vaccines, we would do better off fully explaining it. But that's different than saying, I think that this whatever is going on now is better. I think it's pretty clearly much, much, much worse.
Were you depressed by that?
Yes, I find this very depressing. I think it's depressing and it's upset. I find it depressing. I find it very upsetting because of the number of people who then write to me and say either, what on earth is going on? Am I going to be able to get my kid vaccinated? Am I going to be able to vaccinate in pregnancy? People who write to me say, oh my God, I got vaccinated during pregnancy, but now I'm worried that I've ruined my baby. Just like the number of different things that this chaos has wrought for people. And then the next day to have the CDC come out and say, well, actually, we are going to do this and we've changed this. It's just like uncertainty in this way is really, really bad for everyone.
Kennedy says that, we need to replicate a lot of studies. We haven't done a good job so far. As a data person, how do you feel the quality of the evidence is in general on our public health front, especially around vaccines and perhaps, let's say, just say the link to autism? Do you think we need to do a lot of this replication work, or is the data good?
I think there are places where I don't where I think the data is not good. I think the data on vaccines feels to me very clear and good. I think we have a lot of evidence on both the benefits of vaccines and then also on the risks and on the things that are risks of vaccines. I mean, I don't think it's right to say there are no risks to vaccines. Everybody, it's a medical treatment, has some small risks. The evidence on autism, I think, is pretty unequivocal. I think the idea that autism has gone up, there's not a lot of reason to have even generated that hypothesis, never mind proved it, given what we see in the data. So I think the evidence on vaccines, I'm very happy with where we are. And I think placebo-controlled trials don't make any sense there's a bunch of reasons why the sort of true placebo-controlled trial of routine childhood vaccines is not ethical. There are certainly places where they are pushing for more research where I would like to see more research, like ultra-processed. I would like to understand a bit better, like ultra-processed foods. And, I think we know something about them. I think that there's space to learn a bit more about, what are the kinds of things that matter most.
Final question, Emily. I think there's this moment right now where a lot of folks that we speak with in public health are in resistance mode, that anything that comes out of this administration and that anything that comes out of Make America Healthy Again movement and Kennedy needs to be fought because it is all being done kind of against the gold standard of science and that it's bad faith. How would you advise public health to operate in this moment, to show up in this moment?
There are pieces of the Make America Healthy agenda which are very aligned with where traditional, more left-leaning public health has been over time. For example, let's make kids' school lunches better. That is something that Mrs. Obama wanted. That is something the left has been interested in for a long time. I think that's something that actually is like a very good idea. And while I'm not super optimistic about them getting it done, there's a little bit of like Nixon goes to China on some of those things where maybe this is a shot for pushing some of those things over the line in the way that it may have been difficult to do during a Democratic administration. So I would be worried about people totally giving up and saying, just because these guys don't like the measles vaccine, I'm also now going to decide that like Doritos are a health food. Like we need to be able to hold in our mind that like Doritos are not a health food, and it might be better if like there wasn't strawberry milk at lunch. And if we can make progress on that, that's good, while also pushing back on, measles vaccines. And that's like such a hard nuance. I think it was best when he was first nominated, a friend texted me and said, is RFK going to fix the junk food? Would be great. Shame about the measles. And of course, it's like dark humor, but it has a little bit of that feel of like could we have a both and? I don't know.
Yeah, here we are.
It's funny, Emily. I find myself like today on this conversation, I'm like getting like emotion. It's like an emotional topic. Like, why does this make us so upset?
Yes, it makes us upset. I agree. Makes us upset. I'm
also,
not sure.
This conversation flew by.
Yes.
Oh my God.
This was great.
Anyway.
Thank you, guys.
Thank you.
Well, listen, Emily Oster, the author of so many books and just lighting
a terrific parent website.
Parent data is really good.
Parent data.
Instagram, parent data.
Please visit.
Data, potato.
Exactly.
Really
right. And we want to thank you. You light a fire under a lot of people and you make them think. And for that, we are grateful. We are Why Should I Trust You podcast. I'm Brenda Adhikari. She is Maggie Bartlett, Tom Johnson, Dr. Mark. A huge thank you to Emily Oster for being our guest today. And please send questions, comments to questions@whyshoulditrustyou.net. And we'll see you right back here next week.